And I would like to share a few thoughts and discuss a little bit with you what are the options that we have in a special cohort of patients, the adults with congenital heart disease. So talking about mitral and tricuspid valves and pathology in there. And I have no conflicts of interest. So why is this topic emerging at all? So what are we? Why are we here? Well, we have a great result of innovations in congenital heart disease treatment over the decades, and now reaching approximately 95 and or even more % of success over the years. And this has been now continuous for at least last 2 decades. So there was a tremendous success over the last 70, 80 years in terms of therapy. And if you look at the numbers now, and from my home country in Germany, so these bars show you what really happened in the 70s. We just had the light blue ones. These were the live births and congenital heart disease. Then we started to do the surgery and treatment of the kids in the 70s and 80s. So this population increased, and the 18 years old, the orange ones showed up, and they got treated as well. And by now we are getting more and more of the adults, the dark blue ones, with congenital heart disease. And currently we are approximately at the point where we have more adults with congenital heart disease than the pediatric or teenagers. And rough estimates are somewhere between 250 and 350,000 patients in Germany. We don't know exactly how many they are, to be honest, because there is no registry or something like that which can cover the whole country and include all the patients. We are not so flexible as Scandinavian countries are, for example. So from the surgical standpoint, all these patients show up at a certain point that have some late complications. And I looked up into the European Congenital Heart Surgeons Association database, and over a time span of 20 years, there are 20,000 patients which you can find in that database. So this is just a rough overview. That's also not including really everybody, but it gives you approximately the idea of what is going on. And you see over the years how the number per center increased in treatment of these patients. And if you look a little bit more into detail how many patients have specific defects, you end up approximately a quarter of patients having septal defects, right heart lesions are the same, left heart a little bit less, but then reoperations being again 27%. So, and overall mortality, interestingly, is only about 3%. And this is constantly over the period of the last 10 or 15 years. So I would say, okay, we have a fairly good quality of care and we have a fairly good results, but still the problems we are treating, they may still further develop. So it's not about the result at a certain time point. This is about lifelong management of these patients. And this is practically the topic of the talk. So I would like to go a little bit further into the specific entities one can imagine. So mitral valve stenosis in these patients, grown-ups with congenital heart disease. Finding isolated stenosis is a very rare condition on the mitral valve, and mostly it will be rheumatic type of business or endocarditis, which cause the stenosis, and then the patient shows up. And I would leave the hypoplastic left heart out because you wouldn't treat it there anyway. And what we can offer to these patients is practically a valve replacement. So especially for the heavily calcified valves, it is not very easy to use an interventional valve in these patients in order to secure it well and not cause problems in surrounding structures such as circumflex artery or neighboring aortic valve or the outflow tract. So if you look at the mitral valve regurgitation, this is something we see fairly often in terms of AVSD surgery in the childhood, or in the infancy. And this is a short picture from a situs where the patch is already in there. There is a number of patients which have so-called Schoen complex with mitral valve dysplasia. Rarely isolated regurgitation. Schoen complex goes also with the aortic disease. And also there is a number of patients with endocarditis which would show up regurgitation. And what we can offer here are mostly reconstruction techniques, which we can lend from the adult arena, or some of those are also genuinely being from the pediatric area. But in this case, the interventional therapy, is it MitraClip or even NeoCord, may be an option, and this is something one should think of and one should have in mind that this is something doable for these, and this is something good for these patients. If you switch over to the tricuspid side, the stenosis, again, a very rare entity. You would not find so many of those, except maybe for pulmonary atresia with intact ventricular septum. And again, depending on the side of the right ventricle in these cases, most of the time you would not have so many options to treat this specific entity. And substance-induced and endocarditis, again, can also lead, such as also as in mitral valve, can lead to problems with stenosis. So in my humble opinion, the valve replacement in these cases would be, especially with endocarditis, the only options you can have, because you have to remove the tissue which should not stay there. So if you go to the tricuspid valve regurgitation, this is the largest field in the AAV valve business in the ACHD patients, and there are just a few groups to be mentioned. One of them, which may not be so large, but it's very significant in terms of outcome, are the Fontan hearts, where you have a AV, mostly tricuspid valve regurgitation. Then the Epstein anomaly would be the second one, and then you would have the either congenitally corrected transposition with failing systemic right ventricle, or corrected one with Senning or Mustard. So again, having the problem with the systemic right ventricle, which may fail over the period of decades. That could be after 40 years, but it also could be after 60 years. So we are getting now first patients which will be so old. And again, endocarditis as a regular cause. And many of these patients may even have, especially the CCTGA, a need for pacemakers, so you may find pacemaker leads in there. And there is now a much broader variety of options you can offer to these patients. I would always go for valve repair. Replacement would be a backup option if from a surgical standpoint, but there are certainly patients which would make a clinical benefit if they just get an intervention or even a hybrid procedure. So let's go back to this tale of success I started with, and is it also true for really all the patients, all the adults with congenital heart disease? This is an overview of the patient, and according to the last available German heart report, we had almost 25,000 hospitalizations in this patient population. So here we have the total number for example, because these people showed up in the hospital. But 2.4% is the mortality. And one group is contributing to this mortality, and this is this group highlighted to above 60 years old. We have an increase in mortality between 2011 and 2021, and it's more than double the size, and this is contributing to the vast majority of the increased mortality in the total population on the very right. So we are dealing here with patients, and these are not only surgical cases. This is all the hospitalized patients. So we are dealing here with fairly sick patients, and they need a special care. So let's go a little bit more into detail. From a surgical standpoint, what can we offer them? If I go for a redo case, then I always try to figure out how can I tell the patient or patient's relatives what is the risk. And we have rare cases. We just have single center experience studies, to be honest, but there are no randomized controlled trials. I cannot at least find any of those. And the best bet will be registry data, as I already showed a little bit from the ECHA or Congenital Heart Surgeons Society from the US. Then in Germany, we would even have a chance with the national database, but it has some limitations. And what I would pledge for is establishment of registries which really concentrate only on these patients, and one of them being a Pathfinder registry, which we set up together with guys from Munich and Cologne and Hamburg. And we want to see what is going on with patients who develop heart failure in this area. So going back to surgery planning, so should I do it myself? Should I get an expert for some reason? And if you have a patient like this, heart makes 6, it's maybe a good idea to get a specialist who is dealing with these devices and not try to do that yourself if you're a pediatric cardiac surgeon. But that is also true for other things and also technical aspects. And in terms of technical aspects, many times you end up having the 3rd, the 4th, the 5th redo case. So the aspects of restenotomy, they may be really troublesome and also adding to a very high risk of a surgery. So minimally invasive alternatives is something I would always consider. If you can go from the side, if it has never been operated that way, then you're just lucky. But if it's the second redo from a side, that may be the trouble again because of the adhesions with the lungs. And one very important thing, and this is something which I also needed to learn over my career, is these patients were just, they were put in, well, not put into bed, but they were not even allowed to have sports in school. So the growth of these people was limited. In terms of exercise capacity, they're impaired as grown-ups, and a lot of these patients would just have 2 small vessels. So you would end up with a femoral artery of 5 millimeters or less, and there is no way that you can use these peripheral vessels for cannulation and stuff like that. And again, complexity of the surgery, what's to be done, and so on. These are the aspects I would always think of. And then it doesn't matter how good you are in the OR. A very crucial thing is what's happening afterwards in the ICU. So who is taking care of the patient? Is it the pediatric team? Is it the adult team? What's the availability of the machinery? So what you can offer on which side, and what does the patient really need? Because it may really need Impella and ECMO or even HeartMate, and this is not a genuine business for the pediatric ward, at least not in my case. So these are the things to think of, and these are this is fairly surgical perspective. I agree. Minimal invasive access surgeries would be something advisable, but I would put a limitation more than 10 kilo, and if you agree, and let's take in less than 130 kilograms, which may be even hitting the limit. And in order to replace something or put the AST patch, you can use a partial stenotomy as well. It's not a sin. It's maybe a good way to approach the patient that has never been operated on. But still, redo things, they're emerging and they remain challenging. And this is one example where we did the 5th redo, mitral valve replacement from a side. So now I need some patience. Just a few thoughts about how to do it. This is femoral cannulation. This is practically a standardized business for mitral valve surgery. We are then using for the ACHD patients, you can see over here, and then putting a ring and then repairing it. But as a surgeon, I always try to bear in mind, and also try to train the team, that we need to think about all the available possibilities, because there are so many interventional devices available. So the surgery may not be the best option always. And obviously there would be people who are very prone to interventional therapy, more on, well, even with pediatric cardiologists, but with the other cardiologists as well. So one would ask, why do you need surgery anymore if you have this overview of devices? And you can put these things in, and you don't need a 5th redo for the patient. Well, I would think about it at least once, or not even twice, because think about the anatomy. Just as a short example, you have an AVSD. These are not 2 round valves. You have an oval, large AV valve, and you made 2 D-shaped valves with the correction, with the AVSD correction. So you want to put the round thing in a D-shaped thing. This is not going to be tight. This is you would need at least a couple of paravalvular leakage occluders in order to fix it. And if that would work, it doesn't. It's not always clear. And then you have the calcifications. So this is why I'm saying think about it twice, but think about it. That's my pledge. And I find these things very, very important for high-risk patients where the surgery is hitting the limit. This is an example of DILF with TGA, 2 open shunts, mediastinal seroma, and I'm sure no surgeon wanted to do a redo in this patient. And the symptomatic AV valve regurgitation. This Japanese group just recently published the TER with mitral clip in this patient with a really good result with just a low level tricuspid regurgitation. So as we just saw in the previous talk, for the high risk patient, let's say in this terms, the 85-year-old non-ACHD patient, that's the ACHD patient at the age of 55 to 60. So these people are biologically much older, so just think about it. This is a case where I even said, wouldn't the intervention be better? Because a 35-year-old patient with mustard, TGA, dextrocardia, went to the cath lab, and so my pediatric cardiologist showed the angiogram and said, well, this buffle is not tight anymore. So I said, well, yeah, why don't you just put an occluder and then we are finished, because look at all these wires and stuff like that. Well, he couldn't do that, so we ended up doing the surgery because it was completely calcified mustard patch material. We had to remove it completely. We had to put a new mustard patch in there in order to restore the circulation as is. We did the valve resuspension application at the ring because one of these pacemaker leads was obstructing the AV valve and thereby contributing to the regurgitation, and then at the end refixation, extraction of the lead. So you end up with a really very complex case in this matter. So yeah, the intervention would not be better in the retrospective, at least in this case. I tried to find studies which are covering the ACHD and the AV valve pathologies, and you really do not find many things. So these are practically just single center experience things, like 27 patients here from Bristol in the United Kingdom, and they did a surgical valve repair for isolated tricuspid valve regurgitation. They had really good results with 94% survival at 5 years, which I find really admirable. And even after 5 years, they had still a very good, not only significantly improved clinical status, but almost near to normal clinical status. This is why I also asked the other question. The right ventricular function was good, as well as pulmonary hypertension. So this really a small group of patients shows that, okay, it is doable. You can go for it, and if you do it in a surgical fashion, you can make a difference. Something where we have more experience and idea what to do is the Epstein. It can present at almost any age, so if it's symptomatic, go for it. If it's asymptomatic and exercise test is pathologic, go for it as well. Just for the sake of completeness, neonatal is a completely different entity and with high perinatal mortality. And there was always a question when to do what with Epstein. This was something we were really bothered about. And symptomatic neonatal is the stance, but for the everybody else, the cone repair opened a new era to how to treat these patients. And this is essentially practically very, very elaborative reconstruction of the tricuspid valve, because you need to delaminate everything you got. Then you need to practically create a new valve, suture it together, put it on the exact ring, so you lift it up, and you end up with hopefully good valve result and no regurgitation at the end of the day. So there is even a ATS statement just recently published that cone repair is recommended, and even with asymptomatic patients, the Glenn as a adjunct is for severe RV dysfunction, and you should also look at the left heart and if there is the dysfunction there. And one important point is that the concomitant MACE procedure that should be done as well. So when to intervene, and this is just a brief look into what cardiologists are doing. They compared CCTGA in two groups, one of them having a valve replacement, one without it, and they clearly showed that the patients who have a good status before, and this is what you see on the right-hand side, good preoperative VO2, good systemic blood pressure and the RV, then you can really gain something in these patients. So you really have to be early with these things. And my last thing is about arrhythmia and when to do what. So when to do ablation is always a question in these patients, and this is a multicenter study which compared one group without surgery and ablation with the intervention, and two other groups, one with only repair without ring and the one with ring and replacement. And this last one had the worst results in terms of freedom from recurrent tachycardia after 10 years with just 20%, so it was not good. So the clear message from this study is timing of arrhythmia treatment before or even during the surgery is crucial. So intraoperative cryoablation is something I just found one study, 25 patients, fairly high mortality, so high risk, but very good results. 16 out of 25 patients had, after 14 months, normal sinus rhythm, and 7 of them got a pacemaker. So it's safe, it's efficient, but it has a disease burden with pacemaker. So I would like to conclude. We have many options available for both valves, and we should think of all of them if we want to decide what to do and when. Interventions may be suitable for the patients. We don't know yet. We don't have the studies to decide for it, but we should always see what's the anatomy behind it and what are you treating with this. And the hybrid approach should be considered in complex cases, especially with arrhythmia. And one last sentence. This should be really focused on specialized centers. You need highly motivated teams who have a really broad perspective, broad experience in order to provide these good results as I just reported and to provide good treatment for the patients. Thank you very much for your attention.